Welcome everyone to this session on insights into action for healthcare. We have three leading experts in the field of healthcare from an international perspective. So firstly, we have Dr. Tahir Hussain here, who is the Chief Strategy and Transformation Officer at the Ministry of Health, Saudi Arabia. He will be doing the initial talk and keynote, and that will be followed by a talk and breakout session by Ruth Evans, who is the Managing Director at the Patient Experience Network UK, and Louise Blunt, who is Head of Operations at PEN, Patient Experience Network. A pleasure to have all three of you here together. I'm really looking forward to this session. If I may allow Dr. Tahir, please, to start with your presentation, and then we can move on.
Okay, Hassan, thank you so much. Good afternoon, everyone. As Hassan introduced, I am working with the Ministry of Health Saudi Arabia. And since Ministry of Health Saudi Arabia is going through transformation for the last 3 years now, we have a transformation program already rolled in 3 years ago, in line with the Vision 2030, which is the Kingdom's vision. And there's a marvelous work going on. And somehow the other patient has taken the central seat in this transformation program. And previously, patient has always been very important, but with this transformation, the patient-centeredness has become all the way more important than in the past. So just to further what Hassan has said, that in addition to working with the Ministry of Health Saudi Arabia, in the past I work on the other side of the table, which is the healthcare consumer industry and healthcare pharmaceutical industry. So I have a little sense of both these sides, where delivery and the services and the product industries, they crossroad and they meet each other. But at the end of the day, it's all about making your key stakeholder, which is patient, satisfied, happy, healthy, and it's the patient's well-being is being taken care of holistically. That's what has always been a focus of all the industries. But for the last couple of years in Saudi Arabia, it has become more important. The entire leadership of Ministry of Health is so narrowly focused down on the patient satisfaction that a lot of programs, a lot of enabling programs, they are heavily focused on improving the patient satisfaction, and it is becoming one of the most important indicator, on the way that everyone is looking at it very closely, starting from the top leadership of Ministry of Health and beyond. So, and since I am from healthcare, I'm not a customer satisfaction veteran or expert, but since we have been working on the customer facing industries in the past, so probably combining both of the perspectives, especially now when I'm into the delivery of care. So it gives me a little more room to speak about patient satisfaction from care delivery perspective, more than patient satisfaction or customer satisfaction per se. Okay, so as the topic of my presentation raised, the patient experience beyond 2020. And everyone knows that patient experience or customer experience has changed in 2020. Rather, the entire world has changed. So I'll be touching upon that. Are we talking about a new model after 2020, or the DNA or genomics have been re-engineered with this crisis which we went through since start of the 2020? Then I'll be also talking about a little new phenomena, which might be a little new to rest of the colleagues who have joined here. Is that, are we talking about patient experience, or are we talking about customer experience, or we're talking about combination of both, which is patient's consumer experience? So at the end of the day, patient also is a consumer. So this might be a lateral thought that looking at combining both the till now, these are two different segments in the experience industry. So combining both of them might give a lot of space for the work to be done, which can contribute to patients' experience improvement. Then I'll be talking about the patient experience enterprise. Now, I think there are bits and pieces we've been looking at in the past. So it's a high time, 2020 beyond, that we look at patient experience as with a holistic view and as an enterprise view. So so as I said earlier, are we talking about 2020 beyond, that there will be a new model, or everything's DNA has been re-engineered? My personal belief is that the change has happened at a DNA level now. It is permanent. It will not go back, and there's no reversal for that change now. So either we change, we adapt this change, and revise everything the way we have been doing in the past, to suit and to meet the demands of this changed environment, or we'll be left behind because things have started moving very fast in a new direction set by 2020. So 2020 has changed the way of living to the core, as I said. New models are not just new models. Changes happen at the level of genomics now. Core fundamentals and business fundamentals are changed. The way of doing business is changed. The way of living is changed. So are the customer fundamentals. They're also changed. At the same time, while walking through this first half of 2020, which was just a crisis and filled with challenges, we also felt that the expectations are also changed, and they changed for good. I'm talking about the customers, and I'm talking about the patients. Their expectations are also changed. So, and then from both sides of this spectrum, both ends, the customer and the providers, or the service providers, or the product providers, I think fears and apprehensions are also changed. The nature of the fears, nature of the apprehensions are changed. So, in a nutshell, this change is now for good, and we either we live with it, we adapt to it, or we always will be struggling to match the pace of this change. Change in 2019 versus change in 2020. So it is not that this year 2020 has added to the change. There was always a change for the last couple of decades, especially from the technology perspective. Technological advancements were significant, and but they were too focused on certain areas, certain industries. But I think what has happened in 2020, this change, first of all, the momentum of change has grown significantly, tremendously. Second, the focus has been shifted from certain industries to certain industries. So the momentum has increased. There's much faster change happening than in 2019 and before. And of course, the focus of change has also been have taken a shift to certain industries and certain segments within certain industries. So healthcare industry, as everyone knows, that healthcare industry has always been pretty complex and very regulated industry, which has created a lot of barriers, a lot of taboos, and a lot of challenges from non-healthcare industries to provide services, to provide products, to and services, of course, to I'm talking about the center stakeholder, which is the patient, because of this perception of the complexity and the regulation. So in 2019, technology adoption rates were slower in healthcare industry vis-a-vis other industries. Improvements and transformations before 2019, there were in a balancing act. They were more focused on improvements, short-term transactions, short-term improvements, rather than long-term sustainable improvements, which is transformation. Radical changes were not there. And then the patient experience and the patient centeredness was also part of the improvement, but not part of the transformation. So, so I think this balancing act has come to an end in a way, and this has been expedited by the COVID crisis. And now we're talking about full-scale transformation.
Yeah, we lost you there. We're back on. Yeah.
Okay. Just let me go back. No, just a second, please. All right. Can you see the screen, Hassan?
Yes, very clearly. We can see
Okay,
it.
all right, all right.
Dr. Tahir, if you can go into full view so we can, yeah.
Yes, yeah. Okay, so so sorry for the interruption. I think we are still paying the price for not very advanced in terms of technology utilization. Last was in 2019 change. I was talking about that patient choices and priorities were definitely different till 2019. Now, when it is 2020, change is still there, but change has become explosive. Patient-centeredness is now the essence of transformation. The technology R&D and the tech adoption has seen tremendous traction. A lot of R&D outputs are there, and a lot of R&D inputs are there as compared to the previous periods. The patient-centeredness has gone up on priority, and this is the essence of the core, essence of the value-based care. That the patient should be engaged, patient should be communicated with extensively, and patient should be part of the decision making. And that's the sense of the value-based care, so that the value perceived by the patient should be more than the value provided by the providers. Patient choices jumped up on the system's priorities. Previously, it was all one-way traffic, that provider looks at its own way of doing business, and the patient choices, patient considerations, patient inputs, patient priorities were not considered significantly, and now they are being considered very significantly. So patient has become has become an essential part of the core business. I'm talking about the patient choices. Then is the cross-industrial approximation. Previously, industries had silos, especially when it comes to healthcare industry. There are very few industries working around healthcare. So I think a lot of industries now coming together, joining forces to work on the patient experience. From the pure healthcare perspective, I always, since the COVID started, this is one of the maps which were shared by one of our colleagues, industry colleagues in the past. I just love it. It shows that how we were actually anticipating that the COVID would look like, and how it's changed in terms of the actual COVID impact on hospital utilization. So that period has passed now, and you might see that there is a surge of hospital utilization that we were apprehending and anticipating. This is where we stand right now. And sooner or later, we are almost out of crisis now, and we are in the aftermath of the crisis. I think this is where the new way of living, new way of doing business, new way of providing healthcare is setting in. And that everyone is calling the new normal. So we have entered that phase of new normal, so that we can, what we did as innovation in crisis management will become part of our regular business, part of our routine business. The impact of COVID was not very simple, and it's still unfolding. And it is important for the patient experience industry colleagues and the patient the service providers as well, to understand that there are still many waves, aftermath waves are still expected. And if you can see that there was a first wave which had morbidity and mortality, which happened in the crisis, and now we came out now. And second wave, which was people, those who were there dormant, unattended, and they did not have urgent conditions related to the COVID, but they had non-COVID conditions, and they became urgent in terms of the acuity of the disease. So they have started pouring into the doorsteps of the hospitals and doorsteps of the primary care centers. And then people, those who had critical illness during the COVID, when they were discharged, we are expecting that they will come back with certain complexities which they faced during the COVID morbidity. And then not only at a patient level, but of course at a staff level, the staff, those who were and had been, and so far they are on the front line and the patient facing side, there has been a significant psychological impact. And we can see that there is a burnout, there is a stress on the staff, as well as patients, those who have been part of, they have been COVID impacted. There is around their families, family members, and other circles. There's a lot of growth in number of mental challenges, mental health challenges. So that's another way which we are expecting that it will have. So just to conclude on this slide, that COVID was not a simple phenomenon. So if you do not have this holistic picture and holistic view of aftermath, probably will be missing on a lot of elements which are important and which are essential to put together the patient experience management and improvement programs.
Sorry for interruption, Dr. Tahir. For the last two slides, can you just go back because the y-axis wasn't clear for both of the slides?
Okay, so this one, if you see, this is the utilization level, and this is time period. Utilization of hospital.
The other
operational measure.
Yes, yes, correct. That how much hospital service is being utilized. Okay. So here is the volume and the loads of the patients on the x-axis, and horizontally this is again time frame. So this is very descriptive picture of certain aftermath waves of different types of patient groups, which we are seeing now and which we will be seeing going forward. So it is not exact number, but this shows different types of waves of the different disease groups and the patient groups. Now, still the aftermath is going on. There is still the aftershocks are still there. So what we are seeing right now on the ground is, I'm giving the industry averages, not any particular system or a particular sector, but I'm giving the industry averages that still patients are scared to come to the hospitals, to the facilities, despite there are urgent needs they want, but they are just trying to avoid as much as possible their visit to the hospital, their visit to the medical facilities. So medical cancellations or consultation cancellations are around 30% still. And elective surgery cancellations are also around 20%. And patients have agreeably and with willingness, they have canceled their surgeries and they have deferred their surgeries or postponed their surgeries just because still, the COVID impact is hot, at least the perceptual impact. And then patient satisfaction for the last few months, we have seen that it's swinging 50% up and down, week-on-week basis, month-on-month basis. So there's no stable patterns of patient satisfaction. Maybe patient is swinging between virtual consultations, between physical on-site consultations, or patient is canceling, patient is facing challenges, and there are some access issue because of the technology challenges, so virtual access. So the patient satisfaction, we see that it's still, there's a stable pattern coming out of a crisis, still up and down out there. Patient expectations have changed tremendously. And we have also observed on ground that the patient's expectations have gone sky high as compared to the prior period. And at the same time, the staff burnout is significant because there were nurses shortages across Middle East. I've not yet seen a single sector where we have not seen healthcare workers shortage. So staff was stretched, and the stress of facing the COVID patients was also very high. So there's a burnout. And then is that pre-2020 patient experience model will be still effective or implementable, or we need to consider different models. So this is what we're looking at it right now, that at the end of the day, what is at stake is the trust of the healthcare service provider. Trust is at stake from the patient point of view. So, so if the nutshell of patient experience is that we build the trust between the provider and between the patient. So the patient can trust that the provider he is seeking attention from is very keen on his or her well-being, is very keen on his recovery, is very keen on his safety, and he's also taking care of the risk and other measures of paramount importance from patient perspective. So trust is at the stake. So beyond 2020, expectations will be new from providers, from stakeholders, from community, and from the patient. New model of patient experience we have to create and adopt and implement. And there's definitely a very revised and fast track adoption of new technologies. Previously, there was no. I think Zoom is a very important example. I always quote as that Zoom pre-COVID was different. Now Zoom is as a multi-billion-dollar company. So and that's being used within the healthcare sector as well. And so are the other technologies which are being adopted very fast as compared to the pre-2020. So even the logistic and supply chain models have been changed. The speed of supplying critical goods is of utmost importance than anything else. Revised performance indicators. Now indicators are different. Previous indicators were different. Now we have moved. Not only the indicators are different, but the indicator levels are also different because the expectations are changed. Partnerships are taking new dimensions, and new kind of partnerships are being you can see them happening across different industries. Work models, shift models have been changed. Work-life balance is a bit disturbed. When I say disturbed, it is just not that it's good or bad, but it's disturbed as compared to the previous period, because a lot of employers, they're looking at work-life that people can work remotely is productive, and a lot of employees, they think that work from remote and from home might not be very productive. And healthcare is a very complex phenomena in this case. Then, of course, the requisite skills and talent mix has been changed, and different mix is coming up now, which is more, especially from a patient-facing perspective, being empathetic is a key competency to have, or a key value to have when we're looking at the talent, or especially on the front line. Of course, when we're doing business differently, all the cost structures have been changed. If expectations are different, technologies are different, then it will have an impact on the cost structures. And of course, similarly, when the cost structures are changed, investment focus also changes with the entire industry's focus shifted. Now, this is something very interesting I'm thinking about, is that is patient experience enough, or customer experience enough? Are they two different phenomena? Or now we start thinking about patient's consumer experience, because at the end of the day, patient is a user, is a beneficiary, is a consumer. So looking at customer expectation, satisfaction, and a patient satisfaction differently in different segments, industries, I think it's time that we combine both of them and approximate both of them as much as possible, so that different leverages can be exchanged. Both of these industries are at crossroads now, patient experience and customer experience. Patient experience industry wants to learn from the pure consumer experience industry, and vice versa. Patient experience had been mythically eccentric and exclusive. There were a lot of myths about patient experience in the past, because healthcare is a very highly regulated industry. So I think this is the time now that we should bust those myths, and we should start looking at more productive engagements with the customer experience service providers and the industries, so that we can learn from them and implement in the patient experience environment. Both of these, as I said earlier, the phenomena are approximating now on the spectrum. Before they were on a scale poles apart. Now they are closing the gap very, very quickly. And then 2020 has sped up all this proximity, and both are coming closer very fast. Now, in terms of both of these segments, when they combine in terms of they share the concepts, they share the processes, how the patient experience and the consumer or the customer experience strategies and tactical plans are developed. And then different processes which we use to either implement those tactical plans or measure those tactical plans also are good to combine. And then, of course, competency and skills. Before, there were two different sectors with two different skills and competency sets, but I think now they are very close. And further closing that gap is pretty important, so that both can enjoy each other's strengths to build their own competency and skills. And then, of course, technology which was previously used by the customer experience or the customer or the consumer sector, was a bit different than the patient experience sector. And I always give example of banking as a benchmark, because banking has been into very sophisticated consumer experience provision of the or use of the technology. And then lastly is the measurement, that both previously were having different benchmark, different measures. I think it's a time that we start looking at them, bringing them more closer and defining measurements which are married to each other's measurements. Another phenomena which I would talk about is that now is the time that we look at the patient experience holistically. When we are thinking of combining consumer experience or customer experience with the pure patient experience, I think we also look at it as from an enterprise point of view. So there are some core areas which patient consumerized experience service providers or people, those who are part of this patient experience, either development of the programs or implemented programs, should look at. One is the value-based care. This is a phenomenon where entire transformation is revolving around that. The value-based care means the best care at best possible cost structures in a nutshell. So, but patient experience and patient satisfaction has a cost side to it and has a revenue side to it. So value-based care is one of the core of this enterprise, which should be considered significantly. Then is integrated healthcare. So previously healthcare was a bit more fragmented. There's a primary care, there's a secondary care, there's a tertiary care, and there are centers of excellence beyond tertiary care. I think now one of the core fundamentals of the healthcare transformation is that we build integrated healthcare systems and networks in which there's a patient continuum, in this there's a care continuum, and patient flow between those different segments is seamless, is smooth, and the communication gap is negligible, and patient is more engaged across the continuum, moves freely between the continuum, and the referral systems and referral back systems are seamless and very user friendly. Then is the corporate commitment. I think no change can happen, no transformation can happen unless there is a corporate commitment. And now when we're looking at the Saudi, especially, there's a tremendous corporate commitment. There's a commitment in the entire top leadership at a kingdom level, as well as at a Ministry of Health level, that there's a huge commitment to make this change happen, and the change should be focused heavily on the patient centeredness, especially the patient satisfaction and the value we deliver to the patient. And then, of course, the collaboration. You may call it simple peer-to-peer collaboration, simple industry collaboration, and you may call it private-public partnership as well, to an extent, to a different scale. So a lot of collaboration is going to be part of this transformation, and this is also pretty important from patient consumerized experience or patient experience point of view as well. So this was the core of enterprise of patient consumerized experience or consumer experience. Now, beyond 2020, I think there are a lot of things that are happening, that there is transformation going on, accountable care organization going on, clusters are being developed. So it's very important to understand the transformation expectations, the accountable care organization perspective, and of course, when clusters and networks are being developed, it's very important to understand how they are being developed and what is their ultimate output or outcome which they need to deliver towards becoming an accountable care organization. Then one very important phenomena is that the population at risk. The high-risk population is on top of the priorities to reduce the risk for that particular segment of the population, especially chronic diseases, especially the road traffic accidents and the trauma and similar some other disease areas. And then, of course, is the corporatization, which is an essential core component of the transformation. That now the networks or systems or clusters are more corporatized, and they'll be becoming more corporatized with proper governance, board oversights, the different board committee oversights, and then there are board-to-board relationships as well. So a very, very strongly structured corporatized environment is building up very fast. And then is the financial impact. Everything should be and has to be seen from a financial impact perspective. So as I said earlier, that the patient satisfaction and a value care delivered to the patient has a tremendous financial impact on this. So I think the patient satisfaction, to the core of my belief, will definitely have a very favorable impact of the overall cost of delivery of care. And then, of course, the new hospitals which are now this is not only Saudi Arabia, but across the world, that the patient flow, the movement of the patient, the comfort of the patient is one of the fundamentals of patient satisfaction. So maybe patient satisfaction industry should work also closely with the hospital design industries and hospital construct industries as well. And last but not the least is the digital health and technology. As I said earlier, that this is important, this is crucial, especially from an integrated healthcare perspective, especially from a patient mobility perspective, risk identification perspective, and of course, from measuring the outcome perspective. I think digital health is crucial to the entire transformation, as well as this is important from a patient experience perspective, that we utilize that technology, especially when the adoption rate is pretty high, interest pretty high. The system is focused on improving digital health and use of digital health in the new way of doing healthcare delivery. Just touching on a few areas which are very important from patient perspective point of view to know, and since this is from the delivery care point of view, that as I said earlier, the risk groups focus is pretty high on certain high risk areas. So similarly, the patient expectations are also different in that high risk group. So is the provider expectation different in that high risk patient groups and disease groups. Workflow integration, especially when we are talking about a fully integrated network between all the care continuum, the primary, the secondary, the tertiary, and beyond that. As well as the data integration, because patient is moving, patient is mobile. So one patient, one EMR, and one patient, one data is an ultimate goal that that data integration should provide, as well as the risk reduction should also be leveraged from the data integration. And then are the care gaps between different care groups, with different care levels. There are care gaps which actually impacts the patient satisfaction. So we need to consider those gaps. Unless we fill those gaps, it's always impossible to meet the patient expectation goals. And then, of course, the personalized care plans. Every patient now is looking for, I'm talking about patient choices, they look for very personalized care plans, which are very specific. And this is provider interest as well. That provider has a personalized care plan for each patient group, so that it has better clinical outcomes, and at the same time, it has better cost outcomes as well as the patient satisfaction outcomes as well. And lastly is the patient outreach, that now technology should reach out to the patient rather than otherwise. So providers now are very keen to reach out to the patient groups which are either not on the radars of the system, but also from other perspective, which is the risk reduction or prevention side of the healthcare provision. This is very important, that a very strong coordination is required between different groups in the industry, as well as the different sectors in the industry. And when I say coordination to build this enterprise, this coordination will be at all level. It will be at a G2G level. It will be at a plan and a prediction level, as you can see. And then in between, all the industry, whether it's healthcare provider side or the service and the product or the patient satisfaction industry, they should coordinate at each level, whether it is an R&D level, or it is a risk identification level, or it's a care planning level. They should speak to each other, and they should join forces. They should join brains to build those plans at all levels, so that at the end of the day, the clinical outcomes are improved, along with the patient satisfaction and along with the cost structures. Just taking it to a different scale is that on one side, we're talking about the care coordination. The care coordination actually is happening within the care system, within the network, within a cluster, within a particular geographic area. That there's a care coordination between the primary care, between the secondary care and primary care, and then between the tertiary care and the rest of the elements. So that care coordination is happening within a healthcare system. But on the other side, there is a significant amount of coordination required with other industries as well. So as I said earlier, that if you look at the base, that there's a care-driven education and skills, which is inside the care coordination, which inside the healthcare system. But on the other side, there's also education and skill requirement from the business point of view. Here, they should join the forces on focusing on education and skills. And then, of course, is the technology. And then here is the technology adoption, here's the technology development, so on and so forth. So R&D, then untraditional way of delivering the care delivery. This is a very important perspective to understand that now healthcare providers are looking at a cost-effective, untraditional way of delivering the care to the patients. And the system, they don't prefer that the hospital should be filled with the patients. Rather than systems should reach out to the patients while they are outside the hospitals and outside the brick and mortar facilities. So for that, very untraditional ways should be considered, untraditional ways should be created. And of course, technology is, at the end of the day, is the core of this. So in terms of planning and capability development within a system, sometimes patient experience or patient consumer experience service providers, they do not look at the groups within the system. There's a top leadership, C-suites and boards, and then there are directly engaged with patient experience executives. There are physicians, there are communication and engagement teams, change management teams, and then middle management is crucial to all what we are doing at the top level. If middle management is not engaged, middle management is not trained enough, there will always be a failure of implementation of a strategy or a plan. And then, of course, there has been in the past that we train the executives, those who are engaged with the patient experience, strategy development or planning development, but we really underestimate the importance of the frontline patient experience, which are really facing the patient, which actually creates the impact on the ground for the patient to improve the patient satisfaction. Then, of course, is the nursing leadership, which is I think if it's in terms of the time, 70% of the time is patients in touch with the nursing rather than the physicians and other staff. So lastly is the cross-cutting measures, which actually cuts everything across the system. Sometimes we do heavily focus on those cross-cutting, and we underestimate the importance of certain groups which have their own group dynamics in terms of the acceptance of that that program, a patient experience improvement program, or the strategic plan for that program, rather than we just focus on few programs which are cross-cutting and we try to push them at a system level. So just to conclude, as I said, that the change has happened permanently. Now we have to live with it. And then I think the patient consumer experience is a new patient experience rather than just patient experience. And then it needs an enterprise holistic approach. And then industry coordination is critical for a successful patient consumer experience improvement. And at the end of the day, the resource mobilization, even if at the system level or at a corporate level or at a government level or at a service provider level, it's important that we align that resource mobilization with what we have said earlier. So that was it for the day. I hope I was able to touch on certain important things from pure healthcare provider perspective, which are very crucial to understand if you would like to improve the patient consumer experience going forward.
Brilliant.
Thank you so much.
Brilliant.
Over to you.
Thank you so much for the insightful presentation, Dr. Tahir. That really does tell us a lot about the direction in which the Saudi government is moving into. Just conscious of time here, however, still like to take some questions for Dr. Tahir from our delegates here. Just 5 minutes, please, if we can have any questions either on the chat or you can voice your questions as well. I mean, as we wait for questions, I had one question was, So since the piece you're talking about, the patient consumer experience for 2020, how has that changed the idea of return on investment for patient experience, especially for government hospitals? Are you now is patient satisfaction and quality of healthcare the core metric, or the imperative that you're running after, or is it now also down to do with financials? Are you looking on a return on investment financially as well? Is that one of the core objectives?
Right.
Yeah.
Hassan, thank you so much. I think I would. It's very difficult for us to separate the patient satisfaction from a return on investment, because at the end of the day, patient satisfaction is also a return on investment. And as you know that the Saudi is a social welfare system in which government has actually taken a lot of initiatives to improve the healthcare system. And there's a heavy funding going on, and the healthcare of the Saudi citizens is of prime importance to the government here. However, we consider that at the end of the day, till we are fully transformed and we have a complete visibility of the cost structures, and we can go into improving the value-based care, I think patient satisfaction would remain as one of the core return on investment fundamentals.
Okay, thank you. We have a question from Ruth Evans. Who is leading the way? Which organizations are collaborating or cooperating with you already in the region? Yeah, interesting question. I think the first one, which actually moved faster than the other, they were the technology providers, especially the medical equipment technology providers. So they came up very fast and they did quick R&D. Now they are doing a lot of remote care technology. They're providing technology on that. They're also providing a lot of R&D support to the healthcare in terms of the expertise, if not just the dollars. They're bringing expertise from the advanced healthcare markets to this part of the world. So they're bringing expertise from other markets and helping do the R&D here locally to an extent, to develop certain technology locally and modify the medical equipment as well to suit the new needs or the new way of providing healthcare. So it was the medical equipment industry which came fast forward very significantly as compared to the other ones. Thank you. Yes, and Anas asks, how do you perceive the future of employee experience for healthcare staff during and after COVID? Okay, if I understood the question, that the employee experience, you said, Hassan? Yes. So how do you perceive the future of employee experience for healthcare staff during COVID and after COVID? Yeah. Right. I think COVID has given us a new perspective. No doubt about that employee engagement was always important, but COVID has given us a very different perspective, that employee engagement, employee motivation, employee experience is of critical importance if we would like to improve patient satisfaction. Both go hand in hand. You cannot improve patient satisfaction unless you have a satisfied employee, or you cannot engage patient unless you have engaged employees. So I think it's very important that we to build patient satisfaction, we build our employee satisfaction first. So a happy employee, as it's a cliche that happy employee is always brings the happy customer. I think this goes for healthcare as well, that employee engagement, employee satisfaction, employee experience is very important if we would like to improve patient satisfaction and patient experience. And we'll take a last question and then we can move on to the next one. So Samana Rizvi asks, he joined a few minutes late. So can you explain the difference in concept between customer experience and patient consumer experience? Okay, interesting. Yeah. People, if the question is coming from anybody who's working in the healthcare industry or hospital industry, he would appreciate that the way we provide services
in consumer environment are different than we provide services in a patient environment. Both have been very different from many perspectives. As I said earlier, that it's a highly regulated industry. Healthcare and hospital industry is very regulated industry, whereas other consumer industries are relatively less regulated. So many determinants actually created this difference or divide between the two. Let me quote an example of banking industry. They just secure the data. Other than that, the security of the data, I think, not very much is of that importance to the banking sector as compared to the patient industry, where so many things are very important for the patient service provider. It's just not the data. Data is one piece of it. So I think the most important thing is that the complexity is that we have been measuring clinical outcomes and recovery as part of measuring the patient experience. Because sometimes patient is happy because the way he has been treated, but the disease is still not there. Clinical outcomes are still not there. That's still, let me give you an example, that if there's a patient group, it's a high risk group. But the certain service provider or healthcare provider has a very good staff on the ground, but their clinical teams are weaker, right? So they will be, the patient at a transaction level would be very happy because the frontline staff is decent enough, if polite enough, they are paying attention to the needs on the spot. But the clinical teams have not been able to deliver the clinical value, which is the core of the healthcare business. If patient is not recovering, the disease is not improving, and patient is still having the same level of acuity. So at the end of the day, that is important from a long-term perspective rather than just transactional happiness of a patient or satisfaction of a patient. So that makes both industries separate. But now, in the past, the patient industry has never considered adopting a consumer way of doing business. Here we believe that nursing is a pure clinical staff, and their clinical skills should be more stronger than any other skill. Whereas in the consumer, I think they look at the other side, that they look at the as decently or as strongly as on the demeanor of the staff, other than the pure skill set. So I think now it's coming together. Healthcare system provider also need nurses, those who are of a good mindset, pleasant behaviors. They are acceptable from a patient point of view. They're good communicators. They engage patient very well, and they stretch themselves, which was pure consumer trait. Now it's becoming the service provider trait as well in the hospital industry. So that's why I say that before there were two different industries. Now they're coming together. They are ready to share a lot of skills and competencies between them, and a lot of practices and processes between them.
Okay, thank you. And just lastly, one very quick question is about, it's an important one, which is why I'm asking this, have there any studies being done in this within the Saudi Ministry of Health about the correlation between successful patient experience delivery, or the correlation between patient satisfaction and profit and loss and finance and in terms of revenue generation? Is there any kind of study?
A very simple, straightforward answer is that we have just started a transformation journey a couple of years ago, which is a massive transformation program. We are on the way, but yet dollarizing the patient satisfaction impact on the cost, I think still we have not done as yet. However, we are looking at satisfaction very closely, and we are going into details in different services, in emergency services, as well as in other high traffic, high volume patient areas. But in terms of dollarizing, I think yet we are on the way towards that, and sooner we might be able to do that.
Good afternoon, everybody. So what I'm about to do, I shall share my screen and we shall get straight in to our presentation for this afternoon. So where we'd like to start with this is, we show this quite often. It's a picture of the of Death Valley, one of the hottest places on earth. And it's a fairly unforgiving place. And I think you'll agree, and many times in healthcare, we're also in a very unforgiving place. And we can look out and see, sometimes cannot see beyond what we can see in front of us. And it's quite a hard landscape for us to work in. But you know, every now and then, every blue moon, something amazing happens. It rains. And what happens to the desert is it blooms. And what we are hoping to talk through with you today is to see how insight and the use of insight in patient experience can really help take you from what can often be a very barren place into a place where it's a beautiful place. So we're going to talk today quickly about turning insight into action, and you're going to hear from Ruth and myself. We're going to run through it at quite a pace, but you will be able to see the slides later. So objectives for today, just to have a quick explore of insight and patient experience, look at the many forms of insight, why it matters. So building back on some things that Dr. Tahir said, particularly in relation to corporate and the performance side of the business. Patient experience is not just about the fluffy stuff and the nice stuff and the patients. It's a very commercial imperative for our business as well. So turning insight into action, which is the absolute key. How do you take what patients and staff, very importantly, alluding to another question we had, and turn it into action? And we're going to take you more particularly through a number of case studies and then think about what the next steps might be. So just to quickly introduce ourselves, Ruth is founder and managing director of Penn, and I am the head of operations. And our mission, as it says there, is to recognize, share, and celebrate best practice and patient experience, to measure, embed, and sustain this for ongoing improvement. What do we do? Well, we're involved in many different aspects of patient and staff experience, from benchmarking through to networking, collaboration, best practice, accredited learning, as some of you who've been with us have seen over the last couple of days, thought leadership, and recognition and awards. What we thought we'd do is we'd start with a quick example. This is something we often start our conferences or our webinars with. And it's all about hello, my name is. And one of the reasons for bringing it up today, even though we're not today going to ask you to practice it, is that it's a brilliant example of insight in action. Kate Granger, who's the lady on the left, was a doctor. She worked in a hospital just like many of us do. But one day she became really seriously ill and she became a patient. And what she discovered then was that the world of the patient was very different to the world of the doctor. She found people would come into the room and talk over her. They'd come and grab hold of her arm and start taking measurements and looking at her vital statistics. And she became sort of a non-event. She suddenly realized that things were happening around her, but nobody was communicating with her. To cut a long story short, she went home and she moaned to her husband, and her husband turned around to her and said, Kate, don't just moan, do something about it. So she took her insight back to the hospital she was working with, and she started the Hello, My Name Is campaign. It's very, very simple. When you walk into a room, the first thing you say is, hello, my name is. You introduce yourself. And immediately what you've done there is you've created a connection between you and the patient, or between you and anybody else in the room. But certainly you've broken down that initial barrier. She wanted to make sure that you could start that conversation, that you were seeing the patient, not just her disease. And she wanted to focus very much on patient-centric care. So that's a quick example of taking a very simple piece of patient insight and turning it into something actionable. This is now run right the way through the UK. You will go into virtually every hospital and find people with a little badge on it, and they will introduce themselves with hello, my name is. It's a very, very well-established pattern. So before we start, I think what we just wanted to do was bring you up to date and get us all on the same page in terms of understanding what insight is. And what is the difference between insight and feedback? Well, we're going to come on to that on the next page. Essentially, there are a lot of similarities, but insight, if you look at the dictionary definition, is the understanding of hidden truths. And isn't that just the case when we're talking about patient experience and working within our own hospital environments? It's about understanding what people are really thinking about our organisation, what they may be thinking but don't feel like they can say because there isn't a format for them to say it in. And this is, so understanding insight and understanding feedback is all about finding every single way that you can to allow patients to, and their carers and staff, everybody involved in the care, to actually find a voice and tell us what's good, what's bad, what we can do better, what we can change, and engage them with our services to make sure that we are. Neil Churchill is the Director of Patient Experience for NHS England, and his quotation is very apposite. We spend a lot of time collecting feedback, but we need to know how we could spend more time on doing something about it. We often in healthcare get drowned in data, and data for data's sake is a complete waste of time. As we'll hope to show from this, what we're interested in is what we can do with it. So insight, listening to patients' experiences, and it takes the views of the staff as well. It doesn't come from a single source. Okay, that's one of the fundamental differences. Feedback is individual sources of information from patients. Insight itself comes from bringing together all of these different types of insight, of feedback, so that we can actually build a picture of what it is we need to do about it. We're not acting on a single whim or a single idea or thought. So I really just wanted to give you an idea of how it all fits together. There are sort of two different types of feedback, quantitative and qualitative. So quantitative is really, it's the numbers, it's the statistics. And we'll come over and talk about how we might get that out. Then there is the qualitative side of it, the emotional side, the feedback, the free text, where we're actually engaging and finding out exactly what people feel in their own words. That comes in structured and unstructured ways. So are we structuring it through a survey where we're managing it? You know, we're making sure we ask the questions, or is it unstructured so that we're allowing people to feedback whatever they want, wherever they want to? Is it solicited or unsolicited? Are we asking questions, or are we providing them with a platform to give us the answers? We do that regularly now. At the center of that is action. So taking all of those different forms and turning it into action. And at the very center of all of this is people, because it's people that make things happen. Feedback and data for itself is useless on its own. It only becomes actionable insight when we start working with it ourselves. So I just wanted to throw out a very quick question. Please ask in answer in chat. Where do you think we find insight in patient and staff experience? What are the types of places we can find it? And I'll give you an initial example of what I'm looking for. Surveys, for instance, that's one way of seeking feedback and insight from patients. What else might there be? Okay, so focus groups, yeah. Excellent. Anything else people want to put in the chat? Surveys, yeah. What other forms might there be? Calls, yes, absolutely. Phone calls, speaking to people directly. Okay, complaints, absolutely. And community, Sakina, absolutely right. It's getting out into the community and asking the questions. Chatbots, brilliantly. Suggestions, fantastic. You're all getting the idea. Social media, fantastic. So I'm just going to quickly move us on to actually looking at the types and forms of insight. There's a lot there. And I wouldn't say for 1 minute that that's the full list of what we can do. So we talked about things like interviews and surveys. We can do it online. We can do comment cards, mapping. For those of us who are here for the last couple of days with us will know exactly what we mean by mapping. That's looking at the patient journey. Mystery shopping, often used in retail, but very, very useful in healthcare and in looking at patient experience. Recorded calls, voices, focus groups. Observation. I wanted to draw your attention to observation because that's a very key one. And one we don't necessarily think of or use a lot. And that is simply taking that step back and allowing ourselves to see the wood for the trees, just sitting quietly and watching what's going on, understanding everything that's going on around you, seeing how what is happening is impacting not just your patients, but your staff. I think the question to Dr. Tahir about the importance of staff and happy patients. It's really important that we see the two together. So there's just some ideas and some thoughts on insight, on what it might be. And we just thought we'd share with you a quick sort of graph about, the types of insight and where they sit in terms of being very general or very specific, very descriptive, or simply maybe a yes/no answer. And I think you can see there what we're talking about is, surveys. We can be very general with surveys. You can also be very specific. SMS questions are are less descriptive because there is less opportunity. And then we go over to the more descriptive side of it. Patient stories, a very important one, which we'll touch on shortly. And in-depth interviews, focus groups, where we're actually talking to people and getting their input back to us. So just taking us through identifying and using insight, we thought we'd share very quickly the kind of sort of process that you might go through in order to get the best out of using feedback and using it and creating insight. So first of all, what we're suggesting is you determine what you're trying to achieve. So set out where it is, and hopefully you're going to present you with a few case studies. Hopefully you'll see that in action. Then collect. So decide, once you've decided what you're trying to achieve, that will allow you to decide what the appropriate collection methods are of getting the insight and bringing it back in. And if you remember what we said right at the beginning, it's really important that it isn't just about one specific type, that you take one type and then maybe you bring in other types as well around it to give you that full, rich insight into what your patients are really saying about you. And as we said, also about what your staff are saying about you. So then analyze. So you look at all this information, and what we're looking for is patterns, commonalities. What are patients and staff expectations? Where are the gaps? Where are the things we perhaps need to change? What needs doing? Then use that to develop a plan, and always have a really good plan of action. And then critically, when you've developed that plan, actually move it into the implementation phase. And they engage. I've highlighted engagement because right the way through this from beginning to end, it doesn't work unless you are engaging with as many stakeholders as you possibly can. Plan, do, check, act is a very simple process. I'm sure we'll have seen that before. It's Deming's cycle, and you can look that up afterwards. But it's all about making sure that you keep checking what you're doing and going back to it and rolling it forward in continuous improvement. An appreciative inquiry is a different way of looking at information. And I'm just going to ask Ruth to pop in and spend a couple of minutes because that was an area of interest that came out of our last couple of days. Ruth.
Hello everyone, so I'm Ruth Evans and I'm really pleased to see you today. So appreciative inquiry is something that we were hearing is quite a new concept to the teams over in the Middle East. And this is an approach that focuses very much on what works. So it takes an appreciative approach, and rather than typically we're looking at problem solving or what is not working, which let's face it, in healthcare, that's what we're there for, is to try to work out what's wrong with people and make them better. But when we're trying to improve our experience and use insight to take action, often we can learn more from when it does work. So appreciative inquiry focuses on those times when it does work. Perhaps you've gone home and you've had an amazing day, or perhaps a patient has given us a compliment. What happened to enable that to occur? And that's at the heart of appreciative inquiry. There's a lot more to it, but it's this focus on the positives, it's focus on the assets, and not the deficits, which is what problem solving is. You still need to problem solve, but problem solving alone misses all of these brilliant things. And actually, when you take an appreciative approach, you're also building people up, because it's very much focusing on the positivity, the beauty of things when they work, which is a very different approach for people. And so it's very engaging in its style and its form. You'll hear from me again in a few minutes.
Thank you, Ruth. So I just wanted to bring that in because, as I said, it was something that came up. So feel free to ask us about it at any point afterwards. We'd be delighted to tell you all about appreciative inquiry in much more detail. So again, just conscious that I really want to get on to some of the case studies, and we'll have a whistle-stop tour through some of those. But insight is critical, and it is about being clear about objectives, collection, and who you engage with. It's about listening and asking the right questions. Now, to add to the appreciative inquiry thing, one of the things I learned from my father, and he was honoured by the Queen for his work in industry, so I tended to listen to him quite carefully, was that you have 2 of these ears and 1 of these, your mouth, and you should use those in proportion. Sometimes we spend far too much time talking about things. We should be listening all the time, absorbing that and using that information before we speak, before we make assumptions. But insight itself is not enough. We've been talking about that. It's how you plan the project, how you present it, where, the ease of use. It's about staff and stakeholder engagement, and it's that makes it come to life. When you're turning the feedback itself into action, the best people to involve in doing that are the people who gave you the feedback and the insight in the first place. They're the experts. So just coming back to, it is about outcomes. At the end of the day, what we're looking for is improvements. It's about improvements for patients, their care, the quality of their care, the way in which they view the care. But if they are really satisfied with the care that they've been given, they'll use you next time. They'll want to come back to you the next time they have a problem. Their families too. It's really important that we don't forget that behind every patient is usually a family, and they have views and opinions too. It's about the staff, and from the staff point of view, if you're getting it right for staff and patients, the quality of your staff retention will go up, absenteeism will go down. So there's an awful lot of very strong evidence out there to say that if we're using insight correctly, taking the right action with the right people, it's very, very valuable. You know, it's a profit driver for our businesses. Okay, so just for the last sort of 10 or 15 minutes, I just want to take you through a few case studies. Because actually, at the end of the day, we can talk theory all we like. Seeing it in action is really critical. So these, we're going to take them one at a time between Ruth and myself. And these are examples of some of the work that we've been doing, or examples of some of the work that we've collected along the way in terms of the awards that we run and the brilliant work that comes out of those. So first and foremost, I'm going to hand back over to Ruth, and she's going to tell us about the private healthcare example.
So we're sharing these case studies because you'll be working in very similar environments and potentially be facing very similar challenges. So this particular environment, it is a private healthcare company. It is in the UK, but it's a company that provides diagnostics. And a very big proportion of their business is providing MRI, so MRI scans. Interestingly, they were doing a lot right. So they were already getting very high satisfaction scores. So they were already getting scores of about 97.5%, which actually in the UK is not unusual because often patients do give healthcare quite good scores, interestingly, even though we all know there's always room for improvement. But they knew that they were introducing some new processes and some new concepts, but they also knew that they were receiving still a lot of complaints, and in the qualitative feedback, in the verbatims, they were getting a lot of information about what wasn't working, and they knew that they also needed to engage their staff in the process to improve the patient experience. So we started trying to understand a little bit more to support the insight that we knew already, which was the complaints and the comments and the satisfaction scores. And we wanted to supplement that with other insight. So we did some observation. So we spent time in the units alongside the teams. And of course, when you're first there, they're on their best behavior. But when you've been there for 4 hours or 5 hours, you're just part of the paper, of the wallpaper, and they forget you're there. And now you start to see the real experience. But we come in with fresh eyes. And of course, they're used to their mobiles or they're used to their units, and they forget how tatty it can appear to people who are new to that environment. So observation is really important, and ethnography, following patients through the process and their family members. And that gave us a level of insight that we then mapped, which we'll show you in a moment. And off the back of the mapping, we did some co-creation. So once we understood the insight, we co-created the action. So together with very key stakeholders, we worked on specific areas, including working with patients, where we did some survey to understand what matters to them. We co-created some solutions. The outcome for this particular private healthcare company was that they were being measured, if you like, by the CQC. Now, if you don't know the CQC, it's the national body that evaluates all healthcare suppliers or providers in the UK and gives you a grading from outstanding through to special measures. And special measures is where you are given help, whether you like it or not, because you're underperforming significantly. In the past, they had been getting good. They weren't a poor provider, but they were a good provider. But following this intervention, where they were really trying to dig deep into the insight and move that into action, which was, in this specific case, a whole training program with a series of behavioral nudges. And by that, I mean reminders after the training of things that people needed to be doing. They have now received, literally just received, an outstanding with a special mention for the patient experience that they're delivering, which is a huge accolade to the work the particular company was doing. So that's one example of using insight, defining the action, which was this program to change behaviors, because ultimately the complaints, when we looked at them, were all about people. Actually, interestingly, the process they were worried about, which was introducing what they call smart booking, which means you've only got 15 minutes on the bed, that's not been an issue, and patient experience has been recognised as outstanding. So that's the first one. If there's any questions, put them into chat. We'll keep the momentum going because we know we've got to stop time today. So Louise, back over to you.
Thank you very much indeed, Ruth. A really interesting project, that one. I loved being involved with it, and some phenomenal outcomes from actually developing those various types of insight and turning them into action. So just to give you a quick example of some work that we did in the Middle East, and this focused around surveys. So we started with the available survey data, and I'm sure you're all aware of things like the Press Ganey and the Plane Tree that is widely used to evaluate and to give feedback and insight into services in hospitals in the Middle East. So we took a lot of information on a particular hospital, looked at it from all angles, and analysed it and looked for the gaps and the areas to be developed. From that, we developed another questionnaire, but this time very specifically a staff questionnaire in order to explore their understanding of the patient perspective, then their views on it. So we've taken the views of patients and we've taken the views of staff through a structured survey way of looking. And then we sat down and we developed a bespoke training program that allowed the hospital to take its frontline staff and its managers and senior clinicians to slightly different programs through to understand patient experience and to take some really very, very interactive way of working. It tends to be our way of doing things. We're not breaking out into breakout rooms today, but those who've been with us know how we're working. So it's very interactive, very engaging, and we deliver tools that way to ensure that the hospitals themselves can take that training and embed it within their hospitals. So that was an example from the Middle East. Back to Ruth.
Our next example is a really interesting one because it was actually cross-country, interestingly. So we were working with 3 countries, and we invited 10 hospitals to join a collaboration. I was very interested to hear about Dr. Tahir's views on collaboration. What they wanted to do was, all our hospitals were already collecting quite a lot of insight, but it wasn't real time. So the challenge with the insight was, by the time it had been analysed and action being planned, it was already potentially 3 or 4 months after the insight was collected. And it's very hard to sell those ideas back in when you've already moved on, perhaps on the ward or in the clinic. So we wanted to create a collaborative where we had 10 equal partners, so these were hospitals, who were willing to move to a real-time insight model. So literally the next day, you got feedback about how that experience had been for the patients. And you were taking action on that within the week. And so, of course, there was a lot of work to develop the structures, the process. It was peer-to-peer, so the 10 hospitals learned from each other. So they were brought back together. This is on pre-COVID, but it could be done virtually. We had 4 days where between each day, the hospitals had to go back and implement activity. So perhaps after day 1, which was an introduction to the concept and the models, go back and implement the infrastructure. Day 2 was then working out how do we really listen to the feedback and take action. And then they went back and needed to implement off the feedback. And at the end of the process, it was a 12-month process. So over the collaboration, we met 5 times. The 5th day was a celebration, because every organization had uplifted their measurements, the critical measurements, significantly. At least one measure had improved dramatically, and the majority of the metrics had uplifted in a way that was significant, and was above the national average. So for their country, it was above the average. So that was using a collaborative approach and taking insight, making it real time. And the action was relevant and individual to the organization. We weren't defining the action that they needed to take, but they were taking the action within a week, 2 weeks of receiving the insight. And that's what drove the improvement. Back to you, Louise. Don't forget, questions in chat. Happy to take you through them.
Thank you very much indeed, Ruth. So another example of how to turn insight into action. This came through our Patient Experience Network National Awards. This is not a piece of work that we did ourselves, but it's a piece of work that we uncovered, and we have then gone on to share and work with other organisations to understand the real value of this. And this was all about staff insight. So, but it started with a ward that was having real problems. It had a very long-term patient on it who had been extremely disruptive to the ward. And I'm sure we've all come across situations like that. And over the period of 18 months that patient had been there, it had really taken down the staff's morale. There'd been a lot of absenteeism, simply because of the aggression and the negative vibes this patient brought. So when that patient eventually left, the hospital had a very, very big job then of how do you pick up a team who has got to the point where it just doesn't know which way to turn anymore. So they actually started off their process listening to staff. It was a listening to staff. So how do we do that? How do we listen effectively to staff and make sure that we are getting all of the information we need from them in order to really effectively make change for the staff? And as we talked about before, if you get it right for the staff, you get it right for the patients. So, you know, this is not something where you can just go out and say, well, come on, tell me what's wrong. You know, I just want to know, because they got to the point where they didn't want to do that. So they set up a very clever little, just a very simple staff feedback mechanism, just a whiteboard that went out in the ward and just asked some questions so that people could post anonymously about what their concerns were, what the problems were, what the issues were, what they way we're thinking, what they would like to see changing, and using an appreciative inquiry point of view, what they really enjoyed and what they wanted to do more of. And every day the ward sister would take those comments, and overnight she'd post back answers. So again, very immediate feedback and response, taking a very standard way of doing things, which is the you said, we did. So you said this, we did that, or we are going to do that, or we will talk to you about that. So taking action. They asked the staff for suggestions as to how to make improvements. So they asked staff as to what they would like to see. And they took action on those immediately, wherever they could. They took action. And of course, those quick wins are really important because it got back to the staff that they were really taking action and they were doing it. And it built up a head of steam. So they looked for lots of little quick wins. And then as things started to improve and the staff started to feel more comfortable and back in the zone again, they started to come forward with some brilliant ideas. And I will just share with you one of them that came out of this. We all know that when older people are in hospital, that their hearing aids, quite often they go missing very regularly. And of course, it's the hospital's responsibility to replace them. And they were losing hundreds of hearing aids every year, and it was costing many thousands of pounds to the hospital. So one of the staff said, oh, hang on a minute. Why don't we use these little clear plastic business card boxes? Cost 18p. So every bed had a little box put beside it. The hearing aids went in there. And to cut a very long story short, guess what? No hearing aids went missing. And the total saving to the organisation was somewhere in the region of £25,000 just for that very small idea. Absolutely amazing. So that's the idea of listening to staff, understanding what matters to them, taking their ideas and running with them, not questioning them, just implementing them. And then that leads to the embedding of a culture for improvement. Back over to Ruth.
I know we're getting close on time. I think we'll probably need another 5 to 10 minutes, but I hope you're enjoying these. We love working with organisations to use insight and take action. This was a really interesting piece of work. And again, I'm sure many of you it will resonate with you. So this was a maternity experience. So interesting because of course, maternity patients don't always consider themselves to be patients because they're not there for a bad reason. They're there to have a baby. However, we were working with the policymakers, so we were working with the core team who commissioned services, and they knew that people who have a learning disability, so people who are perhaps not able to read so well, or maybe have ADHD, or any of the learning disabilities out there, they were not having a great experience of maternity. And in fact, 90% of mums and dads who had a learning disability had their baby taken away from them because of their learning disability. And they wanted to use some insight to understand what they could do to change that experience. It may be that the baby still needs to be taken away, but can they change the experience to make it a better experience for all of those involved? Because this is an integrated solution, because of course you've got social workers, you've got various teams in hospitals, you've got charities not in the hospital, you've got a lot of stakeholders in this particular pathway. And we co-created, we spent time with mums with learning disabilities. And this was a particularly interesting project because the insight that we gained was, I led this particular project, but I led it with a mum who had a learning disability. This was right from the outset a shared initiative. So any decision we made, any insight we collected was decided by both me and Catherine, who was the mum I was working with. And we held focus groups and we held co-creation with mums and dads who had a learning disability. And what they did was one of the things that we wanted to, or they said they wanted to do, was what they called the ladder of power. And this was really, really important for them because it showed the people who are making policy decisions, who were deciding things about the experience, the maternity experience for parents with a learning disability, where they felt they were on this ladder of power. And basically, the shocking thing is, as a mum myself, I want to be in control of what's happening to me and my child and my baby. I understand as a new mum, I don't know that much. But what these ladies and gentlemen were telling us, that in the ladder of power, everyone, absolutely everyone was above them. And that was part of the problem. They felt powerless. They didn't have a say. And just because they have a learning disability doesn't mean that their opinion does not count. And so this ladder of power was a really key moment of truth, if you like, of the action that was taken after this, because this went to all of the policymakers to help them understand how parents with a learning disability felt and where they felt they were in the ladder of power. And this was used both locally to change the pathway, but also nationally. So really interesting action off the back of some insight, and a very different way of delivering that insight, if you like, to make a difference so that the actions mattered. I don't know that we've changed the 90% of babies that are taken away from parents with a learning disability, but I'd like to think that certainly up in Yorkshire, where this piece of work was led, that experience has changed dramatically. I'd like to hand back to Louise.
Thank you, Ruth. So very quickly, I'm going to really fly through this because there's an interesting one that we were going to present in full, but I will fly through that too and invite you to see the presentation on our website. But this is for people with sight impairment. This was a really interesting project because going back to talking about how using insight is a really critical thing where you're bringing lots of things together. This particular project involved speaking to people with sight impairment and trying to understand and get out of them, hear their voice. The original idea behind it was that we got 100 voices. That was the whole program. And those voices could be written, they could be audio, they could be video, whichever way we wanted to do. And although you can see on the screen, it said 50 audio and video recordings. Well, that was 10 times what we were originally expecting in terms of that particular metric. We ended up with over 350 voices as a result of this program. And I think the success of it was down to the fact that it was a mixed approach, which was interviews, it was stakeholder engagement. So we spoke with the stakeholders. We ran focus groups, very similar to the way the one that Ruth was talking about. And we really listened to people and we gave them the opportunity to speak. So we provided them with a platform and we allowed them to say what they wanted to say. And then we engaged with the stakeholders and presented alongside the people with sight impairment, the outcomes of their voices, and we got them to hear them. So as a result of that, services are being looked at nationally, regionally, and locally. We worked with one organisation, the Manchester Eye Hospital, and they were going through a programme as we were working with them, but actually accelerated it as a result of some of the things that came back. And they now not only deliver from the hospital itself, the main hospital in Manchester, but they're delivering services locally around Manchester.
Louise, I think there's just one thing I'd like to add, because as people are listening, perhaps this is not coming clear. This is not just about our work. This is actually about things that you can do in the workplace. And one of the things that I'm particularly keen to emphasize is sometimes when you're looking to collect insight, you're told that some groups are hard to reach, and perhaps they're too hard to reach to bother to get the insight. And I'm hoping what we're sharing with you, parents with a learning disability who've had a baby and are willing to talk to us, could be considered really hard to reach. People who are blind or visually impaired, they can be quite hard to reach through the normal routes. And we've worked with people who are in the justice system or young people who are at prison, for example. And I think the key thing is when you're tackling a project, first of all, if anyone says they're too hard to reach, don't worry. Challenge that. I just wanted to say that before Louise moved on. We challenge it. We never consider anyone too hard to reach. And I would really recommend that you challenge that as well, because then your action is meaningful because you've got the right people and the insight from the right audiences. Sorry, Louise, I'll hand back over to you.
No, absolutely, absolutely the right point to make, Ruth. So now, in our original timescale, we were going to present this alongside Nikki in its entirety. Now, obviously, what I'm going to try and do is condense this into literally 5 minutes. But what I would thoroughly advise you to do, a lot of these resources and ideas and thoughts are available on the website for you to go and see. This particular project came out of the Penn National Awards, so the National Patient Experience Awards this year, and it's been hugely affecting and influential to the people who've heard it. The presentation on our website is delivered by Nikki herself. I cannot do it justice. Certainly can't do it justice in 3 minutes, but the way in which she delivers it, and if you really listen to the voice and the way in which she's putting it across, this is a masterclass in insight in action, all on its own. So just to bring this to Birmingham Women's and Children's Hospital, Magnolia House is the Centre for Palliative Care and Bereavement, and it didn't exist about 2 years ago. What they wanted to do was ensure that it was designed by families, children and professionals. It was funded through charitable donations, and what you can see there is an artist's impression of what it was going to look like when it was finished. And actually, that is what it looks like today. Now, this is really affecting because they started by looking at family feedback. And I think you'll agree, looking at that, it's actually heartbreaking reading that kind of feedback. So this is what people, these are people who have babies and very, very young children, and they are dying. So it's a really, really difficult situation that they're dealing with. And you can imagine what it's like in a sterile hospital environment when you're trying to cope with bad news and that your child dying. These were the kind of comments. And not being highly critical, that's the situation that many people find themselves in. So they wanted to have a go at transforming the environment. And these are the things that they wanted. Undisturbed conversations, families that can stay after the news and not need to leave, not be pushed out and pushed somewhere else. Space for families to stay together, space where end of life can happen and it isn't in a sterile hospital, and space for bereavement support. So what they did was they got everybody that had a stake in this together. Co-creation design with families, researchers, builders, architects. And what you will see in these pictures is all of those various different people coming together in various different ways and forms. And we talk about co-creation, which is, and particularly the use of art and mixed modalities of art and the way in which people talk, trying to pull every idea from them. But the really important thing is bringing everybody together in various different rooms at different times to get that creativity out and to design that space. So as a result of the collaboration and the co-creation, these are the things that came out. And what you see in the picture there is one of their professionals from the hospital. They set up these little workspaces throughout the hospital to allow people to talk to them and allow people to express what they would like to see in this particular environment. And it allowed them to gain more and more insight into what was brilliant. And when they'd done all of that, what they did was they took people on a shopping expedition. And because they wanted to understand, can you sit in this chair and deliver bad news? Is this space big enough? They wanted to establish touch, smell, what the art and what the feel should be. This all sounds quite fluffy stuff, but it's really fundamental to this particular body of people. So this is what they've ended up with. They went out, this is not hospital furniture. They tried to recreate the rooms that people would have at home. These rooms are big, they're light and they're airy, and they're like that for a reason, because one of the things that people said was, I feel hemmed in. Don't hold me in. Make sure I have space to where I can get out. I can move away. I can have freedom. So you can see in this room, this is a room that they use. The other rooms are used for focus groups, for support, for bereavement support, for those very difficult conversations where doctors can sit down. This room has a bed in it, as you can see, and it's where families can come for end-of-life care. And an example given is a child coming down from ITU, having its tube taken out because end of life is there. And it's about allowing people to stay in one place, to end life in a really positive way. Another garden room, this now is full of flowers and weaves and things. One thing I didn't mention was curves. Curves of the building were seen as really important, and some of the external curves. So these are some of the things, and when Nikki's talking about this, when you listen to it, she talks about the sterility and the blandness of this, and how it really doesn't reflect the emotion and the compassion that goes in to the kind of environment that they've now built. So these are the kind of things that are happening now within that particular unit. Clinical photography is an interesting one, because people think, you know, this is end-of-life care with families, but just as a real tip, they take clinical photography really seriously, because it's about ensuring that families go away with really positive memories, positive as normal family type pictures, not pictures with tubes and things in the background. So clinical photography is a really big part of this end-of-life care. So some of the patient feedback, you know, beautiful, thank you, please know the difference it makes. And the really interesting thing for me was some of the comments from the staff. Now, they have analysed this in much more detail and very professionally, so what I would say to you is go and listen to it. But the comment by the doctor really sticks with me. I think for me, I feel more human there. My own personal guard came down, and it's actually quite fascinating how an environment can actually dictate that. So the environment we were sitting in, it relaxed me. And I think that, I don't know whether it helped the family or not. It certainly did for me. I was less of a doctor. This is one of the examples of the clinical photography. And this situation was a young family. The child was a toddler, and she was dying. She'd never been to the beach. So they recreated the beach within the house, and they took some photographs of them enjoying the beach within the house, so that the child had some wonderful experiences at the end of life. And also the family had some great pictures to take away. And this is the next phase. So because of all the brilliant feedback, because of the analysis, and we talked about metrics, they had two groups of people. One was the university locally, doing the analysis and working with them to make sure that they were really delivering. They're building another one, and this time it's to honour baby loss. Now, I really haven't done that justice. It's like peeling an onion, this particular example of insight in action. And what I would advise you to do is go to the website and unpeel that onion and look at the different layers and work out what it is that you can do. Now, we don't particularly have time to do that today, so I'm going to cut this short. But what we would really like you to think about is what you can take away from these case studies, the things that you can pick up, the little nuances. If you want more information, just get in touch with us. You can tell we're passionate about this stuff. We absolutely love it, and we want to share it with you. And the people that we work with want to share it with you too. So just think about what you can take away from these case studies. Think about what 3 areas you can focus on to improve staff and patient experience, and what 3 forms of insight, maybe new forms that you've seen today, that you might take away. And I'm going to sign off with that. So if you've got any questions or thoughts, I'm happy to take a few questions.
Brilliant. Thank you so much for that, Louise and Ruth. I think we'll stay on for some questions, so please fire away.
And I'm sorry for the fact we gave it to you in a in a very quick fashion, but hopefully you picked up some things.